Hi, everyone. So first, I'd like to acknowledge also the country in which we're all listening in from today. I'm on Yagara Turrbal country in Brisbane. Um, and like Sarah said, I'm a postdoc at the Molly Wadaguga Research Centre at Charles Darwin University. So it's my pleasure to introduce this morning Professor Amal Trivedi, and he is a professor of health services policy and practice at Brown University, so in the States today, and a research investigator at Providence VA Medical Center. He's a general internist health service researcher who focuses on the impact of policies and incentives on the quality, equity, and outcomes of healthcare. Amal has been a Fulbright scholar and has received a Commonwealth-funded Australian American Health Policy Fellowship, and does lots of very prestigious stuff. We have lots of, we're very privileged to be able to hear from this award-winning best paper for the association last year, 2020. And hear all about this paper that used quasi-experimental difference in differences designed to evaluate the consequences of Australia's closing the gap co-payment policy. So as Sarah said, we can't see you, but feel free to put questions in the Q&A or in the chat, and we'll get to them at the end of Amal's talk. So take it away, Amal.
Great. Well, thanks so much. Really appreciate Sarah for inviting me to speak today, and Sophie for that really kind introduction. Really appreciate it. Very excited to share this work. So today I'll be presenting our work on the effects of the Closing the Gap PBS co-payment policy that lowered prescription medication co-payments among Indigenous Australians. There are a number of people to thank and acknowledge right at the outset. First, HSRA ANZ for sponsoring the seminar and for honoring this work with an award. And then I'd also like to thank the Fulbright Australian American Commission for supporting a Fulbright Fellowship during which we did most of this work. And then of course the Sachs Institute and the 45 and up study that provided data. And of course I want to acknowledge really the instrumental contributions of Margaret Kelleher, who unfortunately passed away in March. Margaret was a brilliant scientist and researcher, and really a dear friend. And we collaborated really not just on this study, but that I'm presenting today, but on a whole range of research projects. Over the past 7 years, it really started when she first hosted me for a sabbatical at the University of Melbourne in 2014. And I remember emailing Margaret in 2013 and asking if she would be kind enough to host me, and she immediately responded, and was really one of those people where I, within 5 minutes of meeting her, knew that we would be friends and that she would have a tremendous impact on my work. And so Margaret's passing left an incredible loss, not just for those who worked with her and knew her personally, but really on the entire field of public health and health equity research. I am gonna just briefly touch on this. Sophie covered my background pretty well, but I do want to mention that I spent really 2 years in Australia in 2014 and 2018, both at the University of Melbourne conducting health policy research. And I'm a big believer in the power of cross-national learning, especially around policies to address healthcare disparities and improve quality. And those are really two of the most impactful experiences in my career. And we relocated with my family, and we all consider Australia to be a second home for us. And so it's great to sort of be in your company and to meet all of you virtually. And I'm really very much looking forward to the moment when we can meet in person in the future. So just to organize our talk today, I'll be covering the context for efforts to increase access to medications for Indigenous Australians, then this study in more detail on the effect of the Closing the Gap PBS copayment incentive on medication utilization and spending, and then I'll close with some implications and future directions for this work. To set the stage, the gap in life expectancy between Indigenous and non-Indigenous Australians is a long-standing and critical issue facing public health and health policy making in Australia. And this graph shows the magnitude of the gap in life expectancy, which is about 10.6 years for Indigenous males and 9.6 years for Indigenous females. And you can see how the gap compares to those in New Zealand between Maori and non-Maori New Zealanders, as well as the black-white racial gap in the United States and the gap between Native Americans and whites in the United States. This gap in life expectancy really occurs throughout the lifespan. Including even through the age of 50, there are still significant disparities in life expectancy between Australian Indigenous and non-Indigenous populations. And they don't even begin to close even until late in life. The primary drivers of the disparity in life expectancy between Indigenous and non-Indigenous Australians is the differential prevalence of chronic conditions. So this graph shows the difference in the prevalence of diabetes between Indigenous and non-Indigenous Australians, and shows that if we look at the middle range, 45 to 50-year-old, 54-year-old Australians, there is a approximately 5-fold gap in the prevalence of diabetes, with Indigenous Australians having a 25% prevalence of diabetes and just 5% among non-Indigenous Australians. This is also true for asthma, and really most chronic conditions are more prevalent among Indigenous compared to non-Indigenous Australians, and that is a principal driver of the life expectancy gap. Now, if we take chronic conditions like diabetes, cardiovascular disease, and asthma, these are conditions where there are effective medications that can improve outcomes. But when we look at spending, per capita health expenditures among Indigenous and non-Indigenous Australians, the spending on prescription medications is actually higher among non-Indigenous Australians. And this is a report from the Australian Institute for Health and Welfare from 2013, which would not align with the higher prevalence of chronic conditions. But if we look at hospital spending is greater among Indigenous compared to non-Indigenous Australians. So it raises the potential that if there were greater access to medications, including more financial access to medications, because out-of-pocket costs are a principal driver of inadequate access to medication, that perhaps there would be less downstream spending on hospital care and better health outcomes, and perhaps a narrowing of the gap in life expectancy. And so for that reason, over the past 20 years, there have been a number of policy efforts to increase access to medications among Indigenous Australians. It starts with what's called the Section 100 provisions in 1999. And that's a set of policies that supplied PBS medications to remote Aboriginal health services, and allowed those services to supply the medications to patients and clients without a copayment. But again, those Section 100 provisions only apply to remote Aboriginal health services. So this was expanded to what's called QMAX in 2008. And here, the focus of this policy was on non-remote Aboriginal and community-controlled health services, and it provided copayment assistance, but the funding was capped at just $11 million, and it ultimately served only 20% of eligible clients. So it was a rather restricted program, and Closing the Gap dramatically expanded access to medications with reduced copayments That was implemented in 2010. And here's what it did. So it started in July of 2010, and it applied to all non-remote general practice. So both Aboriginal and community-controlled health services, as well as mainstream general practice. And what it did was reduce the monthly medication copayment to $5.40. That's down from a maximum of $35 for non-concessional patients. And it waived copayments entirely, meaning free medication, for those who were already had concessional status. The registration was through the GP, and it applied to all Indigenous adults with what's, quote, with chronic disease or who are at risk for chronic disease, unquote. So that's a very broad set of criteria. In fact, one would argue that basically everyone is at risk for chronic disease. So it's quite expansive, but that is the criteria. And there was actually some discretion in how that was interpreted across GPs' practices. Some other key features, unlike QMAX, it was uncapped, so there was no cap on the amount of money that the government would spend on this program. It was estimated to cover 70,000 Indigenous persons at a cost of about 90 million. But by 2012, excuse me, it actually covered 182,000 Indigenous patients. And I should mention that this was part of a much larger closing the gap effort that totaled $1.6 billion to address Indigenous health disparities. And the PBS copayment measure was really just one part of a multi-pronged strategy to address gaps in health outcomes and life expectancy between Indigenous and non-Indigenous Australians. This is data from the Sentinel Site study that shows some of the geographic variation and uptake of this incentive. Remember, in order to qualify and be registered, it had to occur through a GP's office, and the GP had to believe that that the patient had chronic disease or risk factors for chronic disease. And you can see a rather striking geographic variation. So if we take the highest uptake site in the Sentinel Site study, it was Logan Woodridge in Queensland, where 69% of Indigenous adults were registered for this incentive by 2013. But the areas with the lowest uptake, Derby and East Pilbara, are at 1.5 and 9% respectively. And even if we look at an area that's geographically proximate to Logan Woodridge, Brisbane's uptake rate was 18%. And Logan Woodridge was 4 times higher. So a lot of geographic variation, even within areas that are not separated by a large distance. Okay, so that's the context for efforts to increase access to medications for Indigenous Australians. Now let's delve a little bit further into the effect of this policy. So we used a quasi-experimental difference in difference study, and what we're trying to do is measure the change in outcomes for Indigenous patients who registered for this incentive compared with concurrent trends for matched Indigenous patients who did not register and patients who were yet to register at the same time. So graphically, the way this looks is that we've got 2 groups, a treatment group and a control group. The treatment group is the group of patients who registered for this incentive. The control group are matched Indigenous patients who look very similar in terms of characteristics, but were not registered for this incentive. And we're classifying the effect of treatment as this deviation from the pre-registration trend. And a key assumption of this methodology is that these outcomes would have trended in the same direction if the closing the gap PBS copayment policy had no impact. The sources of data include the 45 and up study, which is one of the world's largest population-based cohorts of older adults. It includes 270,000 adults who reside in New South Wales who are age 45 and older. There were baseline surveys conducted from 2006 to 2008, which is where we draw our cohort. And then there have been multiple follow-up surveys of this same cohort after this baseline period. And then we linked the surveys to PBS medication claims from 2008 through 2014. And our final study population included 1,949 self-identified Indigenous respondents to the 45 and up study. The independent variable and exposure variable is registration for the copayment incentive. And the way that we define that is among non-concessional patients, filling a PBS medication at the concessional level, which was the policy. It essentially reduced the copayment to the concessional level. And then among concessional patients, it's defined as filling a PBS medication with no copayment after the policy was changed in July 1st of 2010. All of the covariates are derived from the baseline 45 and up survey, which is, it's a very rich survey instrument. So these are some of the categories of covariates. They include age, sex, marital status. There are socioeconomic characteristics, including income and education. And then the presence of 5 different comorbid conditions: self-rated health, prior smoking, and self-reported disability. And we'll show this in more detail in a couple slides. The outcomes, there's a measure of utilization, which is the monthly number of prescriptions. And we did this across all medication classes. And then we did some class-specific analyses for lipid lowering, diabetes, and then ACE inhibitor / angiotensin receptor blockers. And the reason that we did more focused analyses within those 3 classes is that those were the 3 classes that accounted for the largest volume of medications filled during the study period. 35% of all medication costs in this cohort were attributed to these 3 classes, which is what you would expect given the high rate of cardiovascular disease, hypertension, and diabetes in this cohort. We also, as an outcome, measured monthly out-of-pocket spending on prescription medications, and then monthly government expenditures on prescription medications. So in terms of our approach, we looked at the characteristics of those who registered and did not register, and then we modeled outcomes using a difference in difference framework. And to more precisely match the treatment in the control group, we use propensity scores with inverse probability of treatment weights to account for baseline differences. Here's our regression specification. We are modeling an outcome Y as a function of an intercept, an interaction between registering for the PBS copayment incentive, then a continuous time variable, person level fixed effects, month dummies, and then the propensity score of the probability of registering for the incentive. And then we use robust standard errors clustered at the person level. And then we did some subgroup analyses for concessional versus non-concessional status. We thought that was critical because concessional copayments were, for the concessional population, the copayments were reduced from $5.40 to free. And then among non-concessional, there was a much larger reduction in copayments from a max of $35 to $5.40. And then we did some subgroup analyses for users of lipid-lowering diabetes or ACE-ARB. Okay, so let's look at some data. These are the characteristics of the registrants and non-registrants after propensity score weighting. You can see the mean age 58.3 and 58.4 for these 2 groups. And on essentially all of these characteristics after the propensity score weighting, the 2 groups were very closely matched with no significant differences and rather modest absolute differences in terms of the characteristics of this study population. But you can see that there's a very high burden of chronic disease in this population. At least 68 to 69% reported at least one chronic condition. 30% were in fair or poor health. And you can see there's a high proportion with an income of less than 20,000 Australian dollars per year. and 57% of the sample had concessional status prior to the policy change. So of the 1,948 Indigenous respondents, 51% registered for this incentive in the first 4.5 years. I think that's pretty remarkable uptake of this policy. That over half of the adult population, this is not even restricting to people with chronic disease, but half of all adults registered in a short amount of time. And you can see in the table that it's pretty steady growth throughout all of these time periods. So even late into the study period from June 2013 to October of 2014, there's still about 28% of all of the registrants acquiring eligibility for this policy in that last study period. Okay, let's first talk about out-of-pocket spending. This is a graph of trends in monthly out-of-pocket spending on prescription medication for registrants and non-registrants. It's fairly noisy, so it's probably easier to look at the lines, which is the 12-month moving average. Registered patients are plotted in green, and the control group, those who did not register, plotted in purple. And what you can see is that the out-of-pocket costs were higher for the registrants, those who ultimately registered for the policy, compared to those who didn't. But then after the policy changed, which is the vertical blue line, the groups flipped, and there was actually a rather large reduction in monthly out-of-pocket spending from a max of $15 per month to about $8 per month over the study period. If we look at what happens before and after registration, we see a even more compelling story. So this is monthly out-of-pocket spending before and after registration, where the vertical blue line is the moment when registration occurs. And you can see that the out-of-pocket spending averages about $16 a month, and then immediately reduces to less than half that amount within a year. And even though this is the monthly, so this is monthly spending on all medications before and after registration. But we found a really interesting pattern when we looked at concessional registrants versus non-concessional. So remember, the concessional registrants are the ones who are the patients who have out-of-pocket spending that was that was reduced to zero. And we can see pretty clearly that after registration, concessional registrants, the out-of-pocket spending went to about $2, between $2 and $3 within a year. But monthly out-of-pocket spending did not change much for the non-concessional registrants. And I'll shed light on why that occurred in a couple of slides. So we'll turn our attention now to medication use. And here, this is on the y-axis, the mean number of prescriptions per month for the registrants, the population that registered for the incentive, and non-registrants, the population that was eligible for this policy but never registered. And for both groups, there was a pretty minimal difference of somewhere between 2 and 2.5 medications per month. And then after the policy changed on July 1st, 2010, there was an increase for the population that registered, and really not much change in utilization of medications for the control group. So this illustrates the rationale for the difference in difference study, that there's really minimal difference before the policy change, and then a deviation in outcomes for these two groups after the policy change. When we stratify by registrants and non-registrants, by concessional and non-concessional status, we see that most of the increase in medication use was among the non-concessional population. This is the group that had the much larger reduction in copayments from a max of $35 to the concessional rate of $5.40. So here, there are kind of two stories between the concessional and the non-concessional patient populations. where people with concessional status had much larger reductions in out-of-pocket costs, but the increase in medication utilization was heavily concentrated among those who were not concessional. If we look at the use of ACE-ARB, a lipid-lowering diabetes medication, we see even more striking increases in the use of these medications right at the time of registration. And so the mean is about 0.3 medications per month among all of these classes, and that approximately tripled within a 2.5-year period after registration. So a rather sizable increase in these 3 medication classes that have been found in randomized trials to improve outcomes for people with cardiovascular disease and diabetes. Now I'll show the results for our adjusted models. So we'll take the 3 main outcomes. The first outcome is the mean monthly number of prescriptions. The baseline for the cohort was 2.1, and the policy or registration for this incentive was associated with a 0.8 increase or 39% relative change in the number of medications. If we look at monthly out-of-pocket spending, the baseline was $14 a month, and that was associated with an $8.65 or 61% relative reduction in monthly out-of-pocket spending. And of course, because of how this policy operated and that the Medicare program is the primary payer of medication costs, there was an increase in government spending of about 40% in our adjusted analyses. So essentially what this policy did was it reduced out-of-pocket costs, transferred more to government spending, and resulted in more use of medications. If we stratify by concessional and non-concessional, this again reaffirms what we saw in the graphs. There was a much larger increase in the number of medications among the non-concessional population, a 157% increase associated with registration, but much larger reductions in out-of-pocket costs among the concessional population. From $14.74 at baseline to less than $3 after registration, or an 84% reduction in out-of-pocket costs. Now I want to focus on these 3 critical classes of lipid-lowering diabetes and antihypertensive medications. And we found in our adjusted results that there were increases in all of these classes from 25% for lipid-lowering medications to 33% for antihypertensives. But again, if we look at, for concessional patients, the increase was much more modest, 9% to 19%. So 9% for diabetes medications, 19% for lipid-lowering medications. But for non-concessional patients, we observed much larger increases, relative increases in the use of these medications after registration for this PBS copayment incentive, from 26% for lipid-lowering medications to more than a doubling of the utilization for antihypertensives, for ACE inhibitors and angiotensin receptor blockers. Okay, so conclusions. First off, there was very high uptake of the PBS copayment incentive within the first 4 years among this population of respondents to the 45 and up survey in New South Wales. But critically, many eligible patients were left out. About half of eligible patients were not registered for this incentive, and there was a very high burden of chronic disease among Indigenous patients who could have qualified for this incentive, but were not registered by their GP. The incentive was associated with decreased out-of-pocket spending and increased use of medications. And the use of medications were particularly increased for non-concessional patients who had the greatest reduction in copayments. and we observed 70 to 100% increases in diabetes and antihypertensive medications, again, among this population that did not have concessional status at baseline. So there are a number of limitations. Probably the biggest limitation is that we're limited to respondents to the 45 and up survey. And so it's unclear if these results generalize outside of New South Wales or to people who did not respond to the survey. But we really did need the linked survey and claims data to really match precisely the characteristics of registrants and non-registrants. Another limitation is that persons are not randomized to the incentive. And so there could be residual selection or other unobserved differences between the registrants and non-registrants, although when we looked at pre-policy trends, it looked like there were rather similar outcomes for those two groups, and there was no indication that there was a deviation in the trends in these outcomes prior to July of 2010. And then we're unable to observe health effects, and I'll talk a little bit about that in a couple slides. But we can't look at mortality because we have not linked to mortality. And so if the PBS copayment incentive was associated with better survival and hence more use of medication, then the effects on out-of-pocket costs may be biased to the null. Okay, so implications in future directions before we open for questions. So it looks like this incentive and this strategy to increase access to prescription medications among Indigenous adults in Australia, they appear to achieve the key policy goal of increasing the use of prescription medications and reducing out-of-pocket costs, the burdens of out-of-pocket costs, although it came with increased government spending. And that there was a substantial increase in diabetes and cardiovascular medications, which were among the three most commonly filled classes. This again is encouraging to policymakers because of the evidence that greater use of these medications in appropriate patients is associated with better outcomes and fewer complications of diabetes, including cardiovascular complications and complications related to kidney failure and other vascular abnormalities. And then this also demonstrates the value of linked survey and claims data in terms of identifying characteristics in a more granular and detailed manner than you can get with typical administrative data. In terms of future directions, I think I hinted at one of them, which is very interested in looking at the effects of this policy on health outcomes. Particularly mortality, but also hospitalizations. There is a literature that greater access to prescription medications can have important offsets in preventing downstream and acute complications of chronic disease. And I wonder if this was true for this policy. That is, although there was greater government spending on medication, it's possible that there might have been some important offsets with respect to reduced spending for acute hospital care. So that is a next step, is to link this data to hospital admission records and to mortality, if it is possible. And so we're, that would be the next goal, is to acquire linked hospital data. And overall, this is, I think, a really powerful example of a strategy to address disparities in access to medications by focusing on a particularly socially disadvantaged population with a high burden of chronic conditions and social risk factors. And it stands in contrast to policies that are neutral with respect to ethnicity, and that a focused policy can be successful in increasing access to essential and effective medications. And it's a cross-cutting policy topic because, at least in the US healthcare system, and I suspect this is true in many health systems, the struggle of paying for medications and affording out-of-pocket payments is one of the leading concerns of the public. And finding strategies to reduce the burden of out-of-pocket spending is crucial. All right, so I will stop there. I'm a firm believer that it's never a bad time to show pictures of koalas, so I'm taking that opportunity now. And it's a reminder of our last trip during our sabbatical. Let me just thank HSRA, ANZ, the association for hosting me. Really looking forward to your questions. And of course, want to thank all of you for participating, and we'll look forward to engaging in dialogue. Thank you.
Thanks so much, Amal. I'm sure everyone's doing a virtual round of applause. Thanks for the koalas. I have a few questions myself, but I see there's one in the chat. So I might read this one out, and audience members, if you've got any questions or comments, please feel free to put them in the chat, and we'll get to them. So David Paris says, great presentation, Amal. Although you found an increased non-concessional use of mean monthly prescriptions, there was a much higher baseline use of medications in the concessional group. Can you comment a bit more on that? Also, do you have a sense of how closing the gap played out in other states beyond New South Wales, particularly whether these outcomes were stronger in urban versus rural non-S100 areas?
Great, thank you for the question. Let me first turn to the difference between the baseline use of medications between concessional and non-concessional patients. So yes, the baseline rate was much higher among concessional patients, and I have kind of two thoughts about why that might be. One is that in order to qualify for concessional payments or co-payments, there's an income limit, and the income limit is quite low, and so there may be a greater burden of chronic conditions among that group because of the association between income and health status. But probably the more likely phenomenon driving that finding is that the co-payments were already much lower among the concessional group. They were already at $5.40. And so there may have been much greater use of medications because the cost sharing was lower before this policy was introduced. And that is kind of my thinking about why the use of medications increased so much more in the non-concessional patient population. It's because the reduction in the co-payment was so much greater in that group. Again, from a max of $33 cut to $5.40, which is a larger change than among the concessional population, where the co-payments were reduced from $5.40 to free. But the last point to make is that even among the non-concessional patient population, the mean income was quite low in this sample. It was on the order of about 20,000 Australian dollars per year. So because we restricted the population to Indigenous respondents, the distribution of incomes among the non-concessional group was much lower than what you would expect among the broader Australian population. Okay, the second question, sorry, could you restate the second question? Oh, about effects outside of New South Wales. Okay.
Yes, yeah.
So this is one thing that I discovered during my 2 fellowships in Australia, which is that getting access to administrative data can be challenging. And so we have linked survey and claims data for New South Wales. We don't have an analog for other states that allow us to match the characteristics of registrants and non-registrants. We have done work looking at broad trends in the use of hospital admissions and uptake in different regions around the country. This is part of a study called the Sentinel Sites Evaluation that Margaret and I did about 5 or 6 years ago. And there we found that the regions in Australia that had the highest uptake of the PBS copayment incentive had the greatest reductions in ambulatory care sensitive admissions. And they were only for chronic admissions and not for acute admissions, which makes sense because acute admissions for things like pneumonia and sepsis are typically not sensitive to ongoing use of chronic medication. So that is an ecologic study, not we didn't have patient level data to the same degree that we did for this. But a great follow-up question would be to replicate this type of analysis in other states outside of New South Wales.
Thanks, Amal. Just before getting to one of the other questions in the chat, I just wanted to hear a bit. So I kind of chuckled a little bit where you said the data showed that the health policy goal was achieved, but the government had to spend more. Boo. When we were talking about inequitable funding per capita, which you mentioned at the beginning, given the great burden of disease, I guess, and maybe this flows into the conversation here on the chat, the Q&A. So Pauline says, Kia ora, Amal, could you please comment on the politics of Close the Gap policy in Australia, and was there opposition in reducing the co-payments based on ethnicity? I'm wondering if you can comment maybe on that, the government attitude to this. Are they happy that they are, and seeing an uptake of medication, or are they lamenting the fact that this is going to cost them more? And also, I guess, how much greater an uptake should we expect to see real differences on the ground to the everyday health and lives of the Aboriginal and Torres Strait Islander people that were, taking these medications?
Great. Thank you for those questions. So let me first kind of tackle the concerns that I've heard from policymakers in Canberra. So I did present a version of this in Canberra. And the feedback that I got was that they thought the findings were reassuring, but that one of the key concerns was that the copayment reduction applied to all medications. So it's in contrast to what's called value-based insurance design that's been implemented in the United States, where here the goal is let's reduce copayments, but let's be selective with the types of medications that have the copayments reduced. So yes, we're comfortable with ARBs because they prevent kidney failure among diabetic patients and lead to fewer heart attacks. Yes to statins, but not to osteoarthritis medication or to peptic ulcer disease, or we're going to draw a distinction based on the quote value of the medication. So that was kind of one concern that I heard, was that the goal was to improve health outcomes, but maybe many of the medications had no bearing on health outcomes. So the fact that a lot of the medications filled under this program were statins and lipid lowering, ACE inhibitors and diabetes medication provided some reassurance in that respect. The other question about kind of the broader impacts, Closing the Gap did a lot of different things, and the medication copayment reduction is really a pretty small part of first, all of the determinants of the gap in life expectancy between Indigenous and non-Indigenous Australians. It is important to people who have chronic conditions, and out-of-pocket costs are definitely a big, potent barrier to receiving effective medications. But this was just one small component of this broader strategy. But it is important to evaluate, if there's going to be an investment in reducing copayments, let's quantify whether, people had more access to medications, whether out-of-pocket costs went down, what was the total amount of spending on medications. I think that's helpful to see the results, though it is a rather small and limited component of what was ultimately done to, in 2010, and what continues to need to be done to address disparities in outcomes.
Mm-hmm. I was wondering.
I'll add just one other point about the spending part, which is that I think the spending part is really incomplete because we only have spending on medications, and that was really kind of one point. I think there are very likely to be important spillovers to less hospital care. And that's important in terms of getting a fuller understanding of the cost consequences of this policy. if we reduce acute admissions, which are so much more expensive than a monthly prescription, that's important to quantify.
Mm-hmm. For sure. I guess so. You know, the focus of this paper was on the data that you had in front of you. I'm interested in terms of the impact and the policy implications from the service user level. So a lot of this requires, you know, the patient to be seeing a healthcare provider and having a good relationship with that health service provider, and also that health service provider being aware of the closing the gap opportunities in terms of payments. Anecdotally, from the work that we do, I know that, you know, many health service staff in the mainstream services are not aware of, you know, the full range of things that are available to mainstream GPs, etc. And I'm really interested to hear what you think here about the implications for community-controlled organisations, Aboriginal community-controlled organisations, which are known to be great bang for buck, you know, preventative healthcare, particularly chronic disease. So whether or not the respondents in your survey, you know, were they part of community-controlled? In particular, this idea of, yeah, I guess the broader preventative health, and if we're talking about putting money where it's you get the best mileage, and these organizations are so incredibly underfunded. Like even just the graph, sorry, the table, one of the first tables you said by region, you had Logan as the greatest uptake, that's South Brisbane, and North Lakes, which is North Brisbane, right? So same distance from the city centre, more or less. South Brisbane has a long history of 40 years of Aboriginal community controlled organisations. The north side at that time did not. So things like that, that interplay that might affect the actual person presenting to the doctor having access or, you know, opportunities for this sort of stuff. Sorry, long-winded.
I mean, it's such a great point. I mean, I think it's one of the implications of this work is just how variable the uptake was, because there were a lot of patients in this sample who would have greatly benefited from reduced co-payments for medication, who had a high burden of chronic disease but were not registered. And why did that happen? Well, I think there were a lot of voltage drops. So first off, you need to have a GP. Second, you need your GP to recognize that you are Indigenous and qualify for this program. Then the GP had to recognize that this program exists. Then the GP had to interpret the risk factors or chronic disease in a way that was expansive and not restrictive. I mean, some GPs might look at that and say, you know, unless you've got established heart disease, you know, maybe you don't qualify. So it's, you know, that matters greatly for policy design. The more complexity you put into something, the more hurdles that are involved in getting registered for this incentive, the lower the uptake and the more variable and discretionary it is. And that's why we're kind of left with kind of these large, small area variations even within Queensland. Now, some of that could be related to the site of care and whether it's Aboriginal community-controlled health services versus other sites. I didn't have access to that level of detail, but it would have been, you know, a huge advance to be able to look at the characteristics of general practices and see what types of general practices had higher uptake rates. Because my sense is that it really does depend on the practice and their awareness and interpretation of this policy. And at least for, you know, the site visits that I've taken to Aboriginal and community-controlled health services clinics, there was a huge awareness of this policy and a lot of proactive steps taken to register people who would benefit from it.
Yeah, definitely. So Jess Rankin's got a question. Hospitals are not eligible to prescribe or dispense, I'm assuming, medications using the Close the Gap medication scheme. although many use PBS prescribing. Some specialist medications, including specialized medications for chronic kidney disease, are only available in the hospital setting. Were you able to see any impact on data of this type of access problem to the Close the Gap medication scheme for patients who needed tertiary care?
No, we weren't able to look at that. I mean, that's a great thought. I would love to get access to data that provides hospital-based prescriptions. If whoever asked the question, if you know of such a data source, would love to hear it. But no, we had access to the outpatient PBS medications. So if people were receiving prescriptions through a hospital and it was not included in PBS, we would not be able to observe it.
Yeah, sorry.
Yeah, I'm not sure how relevant that is to statins and ACE inhibitors, but there may be other types of medications where that might be particularly at play. It depends on the kind of the context of where these medications tend to be prescribed for hospitals.
Yeah, it's interesting, isn't it? You see the policy is working, but also it's not working to the extent that it could be. And I can't help but wonder if it's back to that bittersweet, oh, well, if hospitals were going to do it and everyone was going to do it, we would have no much money, but also maybe have less health inequalities. Anyway, Susie Welsh says, our hospital asks Aboriginal people if they are registered or know about Close the Gap, and if not, we give them a leaflet on it to speak to their GP about. There is a movement to enable hospitals to write Close the Gap scripts for registered patients, but it would be great if they could register them. Do you know if this is being considered?
I'm not aware of that, but I will try to look into that. I mean, I at least during the years of the study of the data that we had, registration was exclusively at GPs practices. The idea of registering at hospitals could potentially expand access, but of course that depends on a patient being seen in the hospital. But it's an interesting idea. I think I'm going to take a look at that and see if it's been implemented.
Sounds good. I just want to go back to Pauline Norris's question earlier, just to make sure that we've adequately talked about. Was there a lot of opposition to reducing co-payments based on ethnicity? So I guess this is maybe an international context question about that aspect. I guess this kind of more strategic Aboriginal and Torres Strait Islander targeted policy approach.
I have not heard about that, and it was a question that I asked of our collaborators because, to be frank, this is not a policy that I could ever imagine being implemented in the United States. They've not expressed to me that there was opposition to it, and I think that's why the Closing the Gap PBS copayment policy built on 20 years of other efforts to increase access to medications for Indigenous populations in Australia, that it didn't come out of a policy vacuum. It built sequentially, first with kind of the Section 100 and then QMAX, and then Closing the Gap in 2010. So I would, if others on the call know of more opposition, I would love to hear it, but at least in talking with other collaborators, I've not heard of that. And it certainly is a distinction between Australia's approach to addressing disparities in access to medication, racial and ethnic disparities, and the universe of options available in the United States.
Very, very different health service context in the US.
Yeah, and political context as well.
Yeah. All right. So audience members, if you've got any last questions, please don't hesitate to pop it in. We've got about 3 minutes left. Amal, maybe if you wanted to spend a moment saying where to next, where would you like, I mean, you've talked a bit about the data linkage and hospital data opportunities. Where do you see the next steps being for this work, I guess, to continue to see this momentum of, you know, good things happening?
Yeah, you know, I think what's missing is the health outcomes piece. So, you know, I think linkage to mortality and hospitalizations. The other part of this is there have been some novel medications that have been identified to reduce the risk of complications for diabetes and kidney disease, and they are quite costly. So a lot of medications in this study were already off patent. Some of these newer agents are not, they're still branded and very expensive. So I think there is the potential for an even wider gap in outcomes between registrants and non-registrants, given the effectiveness of these novel agents. And I'm thinking specifically about the SLGT2 inhibitors that have recently been identified in clinical trials to prevent the onset of kidney disease. So that is another kind of direction that would be really interesting to pursue, would be the use of kind of novel high-cost agents where you know, there'd be kind of more of an impact of having the co-payments reduced through this policy.
All right, cool, thank you. All right, so there's no more questions, and it's one last minute. We're kind of running out of time, so I'll try and David Perez says, I was on the Department of Health Technical Reference Group advising on the design of the policy and in the context of overall $1.6 billion Close the Gap National Partnership Agreement at the time. There was a high degree of support for this policy, and the department was particularly supportive of broad eligibility criteria. Fantastic. All right, so sorry guys, time is running out, and thank you so much, Amal, for making it also with the time difference. I appreciate it's certainly late at night.
It's not too bad. It's just 8 o'clock. It's still early.
All right.
It gets worse as there's more time changes. So no, I'm happy to join. Thank you so much for having me. This is really great, really fun.
An absolute pleasure.
Thanks very much, Sophie and Amal. And we'll have this recording up on our website tomorrow morning. And there's a few other webinars that we've got coming up. So again, have a look at our website for those. Thanks, everybody. Bye.
Thank you. Bye.